All right, I think we're going to go ahead and get started. I would like to welcome everybody very early in the morning. Those of us who are from the East Coast, it's not quite as early, but if there are any West Coasters in the room, you guys are champions. Welcome to the Beyond the Image, Enabling Patient-Centered Care and Health System Growth with CTA plus Heartflow. My name is Kara Santillo. I am the Senior Vice President of Market Access and Reimbursement at Heartflow, and I'm truly honored to be joined by Mary Frances Suter and Julie Hulley from Geisinger Health System in Pennsylvania, who are going to be sharing all of their wisdom in a few minutes. I think everybody's going to learn a lot, and they have some really amazing insights. To kick off, though, we're going to do a brief overview of sort of the problem we're solving, the technology solutions, and then because I lead the reimbursement and market access team at Heartflow, I feel required to give you a reimbursement update as to where everything is, how everything is moving forward. So, just getting started, what is the problem we're solving for? And today, the standard of care, which is different types of non-invasive cardiovascular stress testing, really leaves a lot to be desired. There's a significant number of false positives and false negatives. That's where Heartflow enters and the CTA pathway. And with Heartflow, a patient walks in, receives a CTA, and a more advanced analysis of the coronary arteries is performed. Now, being a company representative, I think I'm obligated to do this slide. However, it's really good to know kind of, as we're referencing different technologies, what are we talking about? So there's 3 different technologies within the Heartflow One platform. The first one is called a roadmap analysis, which is accurately named, and it provides the cardiac imager who is reviewing the CTA kind of a roadmap for where stenosis points of concern, points of interest may be. It's an efficiency tool. Then there is the Heartflow Plaque Analysis, which quantifies and characterizes coronary plaque throughout the arteries. And then the FFRCT analysis, which is a physiology tool, a physiology analysis that maps blood flow around the heart and allows for vessel level, segment level stenosis pinpointing. And can be used to make decisions as to whether or not the patient needs to go to the cath lab, referred for other treatments. And so all 3 of these technologies work together to be able to help clinicians, help cardiac imagers better diagnose coronary artery disease. Today, we're going to drill down a little bit further into plaque analysis. The Heartflow Plaque Analysis is our newest technology. It was FDA approved a few years ago, and we just came out with, released our second or next generation algorithm for Heartflow Plaque Analysis. What you see on the screen is the user interface, which allows the reader to query the coronary arteries, have a 3D model that spins all the way around to be able to see everything in 3D. Also, the straight little squiggly lines up there are straightened CPRs so that you can take the cursor and go up and down and really query all of the vessels to see what types of plaque are going straight down each of the arteries. So you can look at calcified, non-calcified, and low attenuation plaque. Because this is a newer technology, we have performed a significant prospective clinical trial called the DECIDE Registry. The DECIDE Registry is wrapping up now, and how it worked is that a patient with chest pain was referred to go get a CTA. They received the CTA, and the physician prescribed a treatment regimen for them. That treatment regimen was in effect for 90 days. The patient then came back. The physician had the CTA and then also got the plaque analysis. The patient then got a new regimen if the provider decided that it needed to be changed. And then they were tracked for lipids and other biomarkers. And what we found in the early cuts of this trial, which we are very happy to say Geisinger was a part of and has been a great partner through, is that over 50% of the time when the coronary plaque analysis was used, the physicians actually did change the treatment regimen. So the clinical utility of this service is over 50%. And then about a third of the time, patients with calcified plaque of 0, when a plaque analysis was run, they found additional soft plaque or non-calcified plaque, which I thought was a very interesting finding. So if a patient comes in with a calcium score of 0, when a plaque analysis is run about a third of the time, there is actually plaque present. And in that case, many of the providers initiated statins for those patients, which they would not have otherwise. And then we also saw about a 15% decrease in risk of cardiac events, which was due to the significant lipid lowering that came with the enhanced treatment regimen. One question I frequently get is, how do all of these work together? We talked about the roadmap analysis, the FFR, and the plaque analysis. So patient with symptoms gets a CTA. From that CTA, a roadmap analysis is provided that allows the reader to have sort of a checkpoint of where there may be areas of stenosis. The cardiac imager then reads the analysis. About 30% of the time, there is no plaque seen on the CTA. Those symptoms were caused by something else. Those patients are referred back to their general cardiologist or primary care physician for follow-up. About 65 to 70% of the time, though, plaque is observed. When that happens, the current, I'm coming at this from a payer lens because I think it's important to understand kind of where things are covered. The current perspective is that 1 to 70% stenosis is the coverage guidelines for plaque analysis. 40 to 90% stenosis is the coverage guidelines for FFRCT. So there is going to be a subset of patients in the middle where both technologies would be appropriate and used for different reasons. But your lower stenosis range, that would be plaque analysis, higher stenosis range, FFRCT, and then there is an interplay. And I will say, because we're going to get into the reimbursement discussion in a second, these are, both FFRCT and plaque analysis are separately billable services, and so they can be used when medically necessary for the patient in combination if they need to be. All right, very quick overview. I've been doing reimbursement work for a very long time, and typically when you get up to give a presentation on reimbursement, you stand there and you say, we're working on it, it's coming, we're talking to the payers, Medicare is, they understand they're gonna work on something next year. That is not the case with FFRCT and plaque analysis in particular. The reimbursement environment for plaque analysis is rapidly evolving in a positive manner. And this is due to just the clinical evidence and economic story associated with these technologies. So currently FFRCT has 100% coverage. I think I have 99.5 on there. There's one tiny plan in Southern California. We're working on it. But there is 100% coverage for FFRCT when medically necessary. Category 1 code came for FFR in 2024. Plaque analysis, like I said, is evolving. And the way it's evolving is Medicare coverage came on board last year, late last year. We are now seeing the commercial payers catching up. As of October 1st, eviCore, which is the country's largest radiology benefit manager, published coverage guidelines recommending coverage for plaque analysis. United Healthcare, Cigna, and many other major Blues plans have adopted those guidelines or incorporated their own. And the beauty of this, for anybody who has to manage any of this, is that for plaque analysis, everybody has adopted the same coverage guidelines, which rarely happens with a new technology, but makes ordering and understanding what patients this is available for so much easier. The other piece of this is that plaque analysis will be converting to a Category 1 code starting on January 1st, 2026. For any reimbursement nerds in the room, the CPT book was officially published on Wednesday, so I can officially share this code. And so and it will go into effect on January 1. 2 quick notes. Whenever there are Category 3 codes, which are the 4 codes that are on the slide, there are no RVUs associated with that service. Starting January 1, there will be 0.85 work RVUs associated with the interpretation and report of the plaque analysis. And any of you who've already adopted plaque know that there is currently an NCCI edit on plaque and CTA saying that it cannot be performed on the same patient in the same day unless a modifier is used, or plaque would not be separately billable. With conversion to Category 1, that NCCI edit will be removed, and so plaque will be able to be ordered on the same patient on the same day, which just makes the workflow a lot easier. And then just wrapping up here, the proposed rule was released in July, and for 2026, the proposal is to keep the hospital outpatient payments stable for plaque at $950. And the physician office setting, this is the conversion to Category 1, the proposed rate is a little over $1,000. We do anticipate seeing the proposed rules. They're usually out right around Halloween, but the government needs to be open for them to be released. So stay tuned. They might be a little bit late this year, but they will go into effect on January 1. And Heartflow is sponsoring a MedAxiom webinar on December 3rd. Fingers crossed that the government has been reopened and that the rules have been released by that webinar, but hopefully we will be able to give everybody an update as to what was finalized, what's going to be going into effect, and what you need to do to get prepared for 2026. One quick note, you will see there is a decrease in the FFRCT rate for 2020 in the hospital for 2026. I don't think that's going to stand in the final rule, or hopefully there will be some mitigation of that. There was an issue with revenue coding, and if you take away nothing from this speech, please go back and talk to your revenue cycle folks. Medicare made, there was an erroneous edit on both CTA and FFRCT requiring use of the radiology revenue codes. That was never supposed to be there. When Medicare learned of it, they removed it. In true Medicare fashion, they put a 2-line notice in a newsletter that nobody saw. And so we are educating everybody to review your revenue codes. The recommendation from SECT, the Society for Cardiac CT, and MedAxiom is to align with the cardiology revenue codes, which better takes into account the cost basis for these more advanced technologies. And so there's multiple options on the screen. But due to the revenue code issue, there was some erroneous data in the APC calculation for FFR. We've pointed that out to Medicare. We hope they remediate that in the final rule. All right. So I am going to hand it over to the gurus from Geisinger. I'm very excited to hear what they have to say. So I'll have Mary Frances and Julie introduce themselves.
Thank you. Well, hello, Austin. Good morning. Good morning. So I am Mary Frances Suter. I have the pleasure of serving as the Associate Vice President for Geisinger Health System for Cardiology and Neurology. I've been at the organization for a bit over 5 years. By far the best place I've ever worked. I've totally drank the Kool-Aid.
Hi, I'm Julie Hulley, and I am the Revenue Management Practice Consultant Liaison for the Heart and Vascular Institute within Geisinger. I've been in that role for about 3.5 years, and then I've been with Geisinger for almost 13 years. I was a clinical exercise physiologist prior to that time in the Heart and Vascular Institute before transitioning.
So to kind of understand Geisinger, I think it's really important that you understand where we're located in our history. So way back in the day, in 1918, there was a philanthropist by the name of Abigail Geisinger who had married a gentleman who had invested in iron in central Pennsylvania in an area called Danville. Her family was actually one of the original founders of Geisinger. She had the only, of Danville, she had the only car in town. So every time someone needed to go to the hospital, they would come and take Abigail's car and drive them to Bloomsburg, Pennsylvania. So every time Abigail wanted her car, it wasn't there. So Abigail had decided that she was going to build a hospital in Danville to care for the people of Danville. So the Geisinger Health System is an integrated health system. We serve both South Central, Northeastern, and Central Pennsylvania. Just for the sake of history, this is a huge coal mining community. Anthracite coal is where this comes from, this territory. So you can imagine back in the 1800s and early 1900s, this area was very profitable, very a lot of money, a lot of barons living in the area. And then we found wood, and coal kind of went away and wood became important, and then the coal mines began to close, and then the area became what's left of it today, which is incredibly desolate. So we offer primary care, specialty care, hospital. We have a hospital, we have health insurance, we have pharmacy, we have research, and we also have a medical school as well as a nursing school as well as an allied health school. We serve over 3 million patients across 45 counties, 10 hospitals, over 150 clinics, 26,000 employees, and about 650,000 patients enrolled in our health plan, and about 6.7 million lives served throughout the community. So you can see that's Geisinger right there. So in 2024, Geisinger and Kaiser Permanente joined together and formed a new corporation called Risant. I'm sure everyone saw it in the New York Times. Risant is a entity that, like organizations like Geisinger, integrated health systems across the country who care for rural patient populations and or underserved populations, are joining together to form one big conglomerate of hospitals for not only purchasing power, but legislative power, bargaining power, et cetera. So Geisinger was actually the inaugural health system. We've subsequently welcomed our partners, Cone, and very shortly there'll be a third health system that's joining the system. At the end of the day, there'll be 8 health systems underneath the Risant umbrella. The beauty is when you negotiate with Geisinger, you're now negotiating with Risant. So it's an incredible, powerful move. It's based on value-based care, and it's based on high reliable organizations. So we adopted cardiac CT at Geisinger very, very early on. And the reason being, it's 287.5 miles from one hospital to the next. And you can ask me how I know that, because I drive it. So I'm never in the same hospital twice in a week. I'm across the system, so I can tell you that you'll go from an area that is pretty condensed, major metropolitan city, relative in comparison, right? To very, very, very rural communities where it's horse and buggy and people don't go to the doctor. So we adopted cardiac CT really, really early on for the purposes of serving our rural communities. When patients were presenting to the emergency room with atypical chest pain, their ACS score was, indeterminate, we didn't know what to do. The concept was, could we do a cardiac CT on those patients, risk stratify before transferring? So that's how cardiac CT originally came into Geisinger in around 2019. But since then, we've integrated it throughout the system. And it's been all about the outcomes. It's been all about the accuracy of the diagnoses, as well as the cost reduction for Geisinger. So what we have found is, since we introduced it across our platforms, our non-invasive testing volume is actually decreasing. In 2020, our stress echoes were probably our primary imaging modality. And slowly but surely, you can see that cardiac CT is creeping up and taking over that non-invasive testing space for us, which is huge. Our CT volume has grown to 20% of volume change over all our other non-invasive testing, and this is increasing day by day. The more patients hear about cardiac CT, the more they're asking for it. The more that we're educating our communities and our referring physicians, the more they're asking for it. The beauty is their patients are getting an answer. They're able to see their answer, and then you're able to make a decision plan with the patient on treatment. So our average FFR CT utilization in 2024 was about 30%, but this continues to grow. Heartflow has made it incredibly easy for Geisinger to be able to send our images. All of our patients who get a cardiac CT are pre-auth for FFR. The CT automatically goes to Heartflow. It automatically pushes forward. On the physician reading side, they make the decision for what Heartflow should do. They press the button, yes, please image this, plus yes, please FFR. So it's very seamless, it's very easy, and that's why it's growing so rapidly. A cardiac CT with our high-resolution CT scanners is a very short test versus a stress test where patients are there could be there for the whole day. So when you have patients who don't want to spend their entire day at the hospital, physically unable to spend the entire day at the hospital, and or just simply can't tolerate stress testing, this has become an incredible modality for us. So the most important part about cardiac CT with FFR that has changed the paradigm at Geisinger is when the patients are going to the cath lab, they're getting intervention. So our diagnostic to intervention ratio has really rocketed, which of course is much better for reimbursement and much better for the patients. So that's Geisinger. Any questions? Yeah.
What percent of your CT scans are inpatient versus outpatient versus done in the emergency department?
Excellent question. So we are primarily an outpatient cardiac CT FFR department. We do inpatient cardiac CT, particularly for patients who are in OB status. I guess they're not considered inpatient, though, they're OB status. OB status, patients from the emergency room. So I would probably tell you that, well, Julie could probably answer this better than I. She's my Oz behind the curtain when it comes to everything coding, billing, money. You know, she's the one that makes it all look really easy. I would probably say 80-20.
Yes. Yeah.
Our system's been reluctant to do inpatient CT FFR.
Interesting.
Because of reimbursement, which
Yeah.
is not really a great answer. But
Well, if you look at length of stay and cost per day, right? If you figure, med surge bed, telemetry bed, what is that? Potential income, what, $2,500 for the day? You get the patient out of the hospital, you shorten your length of stay by a day, you've already paid for your test.
And I would just to jump in there to say too that with our current program for CV surge patients that have high risk PCI, they go in and have a diagnostic cath and there's an immediate referral to CV surgery. The patient's usually in the inpatient status already, but then the CT and the FFR have been utilized to then really determine the best mode of care for that particular patient, the best mode of intervention. So a lot of our patients are being sort of in roundtable discussions with our interventionalists and our CV surgeons to determine the best mode of intervention. And so it's part of some of the reporting that I do for the Heart and Vascular Institute is to identify those patients that we are really able to then sort of push back to the cath lab and have a staged PCI done before they're discharged, or maybe discharge them and have them come back within a few days to really give them the best possible outcome with the lowest amount of risk.
are you doing CT 7 days a week?
No, we only do CT 5 days a week at present, but we are in the process of a very, very heavy lift of becoming a 7-day-a-week operation. For example, our GI, echo, we have people on call. People will come in, work a portion of the day, and then they'll go home. But we're in the process of making Monday look like Saturday and Sunday. And it's been very interesting because there's a lot of resistance to Saturday and Sunday being a normal work day. I don't know, has anyone else in the organization dealing with that problem where your weekends look very different than your weekdays? Yeah. So that part of being a high reliable organization is moving that forward. I can't say I'm very popular, particularly with people who are now coming in and working holidays and Saturday, Sunday normal schedule. But it's very important, and we're moving to that modality. We're fortunate in Geisinger because cardiology and radiology have a very collaborative, integrative approach. So we have the ability at Geisinger to actually remote in for a more experienced tech who's in another location to help guide the cardiac CT if a patient's at one of our outlying hospitals, to be able to make sure that the quality and consistency of the study is consistent regardless of the location. So that's been huge for us. The other thing that we've actually designed is patients who get cardiac CT who have present to the ED, intermittent risk score, cardiac CT, FFR come back significant, actually straight to the cath lab, treated like a STEMI, which is really exciting because you're really moving the patients along. Instead of them sitting in the hospital for a day, waiting for the next morning, waiting for their stress test, going to the cath lab, waiting, so it's really moving things along.
Are you scanning at night or just during the daytime?
We scan into the evening, but not overnight.
How late do you scan?
11 p.m.
And Mary Frances, one thing, talking about
Cardiac CT. Our normal CT scans all night. Let me clarify that.
yes. So if you want a cardiac CT at Geisinger before 11 p.m. is the answer. Yes. Okay. So speaking of, you talked a little bit about the emergency department. Geisinger, given your geography and your reach, has an innovative approach to leveraging the CTA pathway with the ED. Can you talk about that a little bit?
Sure. So actually, it costs about $13,000. We have our own transport and life flight, et cetera, like a lot of everyone here. On average, it's about $13,000 to transfer a patient from one of our remote hospitals to one of our hub hospitals. So the goal was to implement cardiac CT in all of our emergency rooms for the intermittent risk score, eventually 7 days a week, 24/7, so that we could prevent the unnecessary transfers. We're finding about 30% of transfers from our outlying hospitals or smaller community hospitals come to the one of the main hubs, one of the 3 main hubs, and actually have either no intervention done or just a stress test done or just something along those lines. So it really is the value of the transfer and the outcome that's being done at the hub hospital really worth it for the patient and the family who's being taken out of their community. Remember horse and buggy, right? Taken out of their community to be brought to the main hospital an hour and a half away, and we actually literally do nothing that we couldn't have done at that smaller community hospital. We have hospitalists, and sometimes our hospitalists are very skittish. When a patient says they have, epigastric pain, the immediate reaction is to transfer. So how do you change that culture? How do you get people to understand there's things that we can do to assess the patient's coronary risk and their anatomy prior to transfer?
And Julie, you are the data guru,
Yes,
which
she is.
every system needs a data guru.
And coding.
Yes, absolutely. I was wondering if you could speak a little bit to, with the CTA pathway, what data are you pulling, what are you looking at, and how are you using that to best risk stratify some of the patients?
Sure. So I kind of came into this role right as Geisinger was really hitting the ground running with Heartflow. So initially, the FFRCT codes were CT codes. They were temporary codes, and so as the liaison role in revenue management for the Heart and Vascular Institute, I spent a lot of time looking at our payer mix and our denial risk and how to prevent those denials through efficiencies that we can use with our EMR and our prior authorization team to make sure that we're really kind of staying ahead of the curve, staying ahead of the marathon that it is. And for this particular study that we did in 2024 to sort of support the continuation of our program and really support what we are as a high reliability organization, is to really identify how the market is shifting with the support of FFRCT as compared to the sensitivity or specificity of your SPECT nuke or your stress echo. We've just seen, I was an exercise physiologist in the stress lab for 10 years, so I've seen the technology improve and the patient satisfaction of having a CT versus having a stress echo or a dobutamine or even a spec nuke where, like Mary Frances said, the spec nuke can take 2 or 3 hours to complete if they're having both pre and post scans on the same day. So just seeing that and then being able to come full circle with our CV surgery department and our physicians in the interventional labs to really identify the areas where CTA in between having a positive stress test and sort of your normal stress test modalities versus the CTA can really, and the FFRCT can really support the patient's decision making to determine whether a stage PCI is lower risk, better outcomes versus CV surgery.
Yeah.
So.
All right, we're almost at time, so I have one final question. Given, and I'm the reimbursement person, so I have to ask this. Given where we are with CTA reimbursement doubling this year for Medicare, FFRCT, and then now plaque analysis with the reimbursement environment, and all of the study, all of the clinical trials looking at the benefits of the CTA plus Heartflow pathway, where do you guys see this going in the next few years? How are you gonna grow this? What are the next steps?
So as in my role, that's one of the things that Mary Frances and her leadership team reach out to me to try to identify ways that we can provide this not only as a model for identifying patients that are actively having cardiac symptoms, but also looking at our preventative model. And the initial data that you did from your DECIDE research has really kind of pointed to that opportunity in our area of rural Pennsylvania to really make this an opportunity for patients that hear about this test, have a very strong family history, but maybe don't have any symptoms, but would really like to know what's my status of plaque, what does my heart look like on the inside. And so we're going to start to stand that program up within our system to make this available to primary care physicians who are looking for that prevention for their patients, to be able to really hone into that group, and that will be obviously in addition to the symptomatic patient group that we see.
Yeah, I like to say a picture's worth 1,000 words. When you show somebody their picture that shows that they have these blockages, and then you say, it'd be a really good idea for you to take your medicine, because what happens if you don't take your medicine, it really makes an impact on patients, particularly if they don't, this is huge. This is so complex. People are overwhelmed. But if you show a picture and say, this is what it looks like, and the goal is that medicine will help stop the progression of this, it's absolutely huge. We're launching a familial hypercholesterolemia clinic, and when you see the little people, whose moms and dads, we're all about smoked sausage and cheese in central Pennsylvania. There's something called a fried dipped Oreo. I'm from Philadelphia, so it's been a very big transition for me. But when you see the little people whose parents are suffering from coronary disease and know that if we don't do something today for them, they're going to be our patients of tomorrow. So that's really kind of the direction we're going, and that's the direction we'd love to partner with Heartflow around, the prevention arm, the regression arm, and the familial arm. I think that would be just amazing to revolutionize care for these patients and their families.
Absolutely. Well, I think that's all the time we have for today. I just want to say thank you to everybody for being here, and especially thank you to Julie and Mary Frances for sharing your incredible insights. So we really appreciate you coming, and have a great day at MedAxiom.